Hello everyone. We will be talking about exfoliative erythroderma syndrome (EES). It's also commonly known as exfoliative dermatitis. So you can come across erythroderma, exfoliative dermatitis, or exfoliative erythroderma syndrome. All of them mean the same. So, exfoliative erythroderma syndrome (EES) is a serious and at times life-threatening reaction pattern of the skin that is characterized by generalized and uniform redness and scaling involving practically the entire skin. So, let's take note of the words generalized and uniform redness. So, these words generalized and uniform redness that do not forget. And also it practically involves the entire skin, meaning there is widespread redness. Okay, so it's associated with fever, malaise, shivers, and generalized lymphadenopathy and fever. There are two stages: there is acute and chronic, and sometimes they may merge one into the other. In the acute and subacute phases, there is rapid onset of generalized vivid red erythema and fine brownish scales. The patient feels hot and cold, shivers, and has fever. In chronic AES, the skin thickens and scaling continues and becomes lamellar. Then there's a loss of scalp and body hair, and the nails become thickened and separated from the nail bed, which we commonly call onycholysis. There may be hyperpigmentation or patchy loss of pigment in patients whose normal skin color is brown or black. The most frequent pre-existing skin disorders are in order of frequency psoriasis, atopic dermatitis, adverse cutaneous drug reactions, lymphoma, allergic contact dermatitis, and pityriasis rubra pilaris. Age of onset is usually greater than 50 years. In children, EAS usually results from pityriasis rubra pilaris or atopic dermatitis. And sex, more males are involved compared to are affected more than females. Then etiology. So 50% of patients have history of pre-existing dermatosis. 50% of patients have history of pre-existing dermatosis which is recognizable only in the acute or subacute stage. Most frequent pre-existing skin disorders are in the order of frequency: psoriasis, atopic dermatitis, adverse cutaneous drug reactions, cutaneous T-cell lymphoma, allergic contact dermatitis, and pityriasis rubra pilaris. Drugs most commonly implicated in EES are shown in a table that we're going to see very soon. Then, in 20% of patients, it is not possible to identify the cause by history or histology. So basically, what do we mean when a patient when we receive a patient whom we're suspecting they have erythroderma? So you need to query about the following conditions: does the patient have psoriasis, atopic dermatitis, what drugs has he been taking, any history of cancers, etc. So basically, etiology of exfoliative dermatitis in adults, you can see undetermined 23%, psoriasis, atopic dermatitis, drug allergy, lymphoma, leukemia, allergic contact dermatitis, seborrheic dermatitis, status dermatitis that is with id reaction, pityriasis rubra pilaris, open ficus foliaceus. So let's go here. The metabolic response to exfoliative dermatitis may be profound. Large amounts of warm blood are present in the skin due to the dilatation of capillaries, and there is considerable heat dissipation through insensible fluid loss and by convection. Also, there may be high output cardiac failure. The loss of scales through exfoliation can be considerable, up to 9 grams per meter squared of body surface per day. And this may contribute to the reduction in serum albumin and the edema of the lower extremities, so often noted in these patients. So, you need to know that they usually have edema of the lower extremities, bilateral edema. bilateral pedal edema. So, clinical presentation depending on the etiology, the acute phase may develop rapidly in a drug reaction, lymphoma, eczema, or psoriasis. At this early acute stage, it is still possible to identify the pre existing dermatosis. There is fever, pruritus, fatigue, weakness, anorexia, weight loss, malaise, feeling cold, and shivers. So, what is the appearance of the patient going to be? They'll appear frightened, red, toxic, and it may be malodorous. So, the drugs that we talked about that are likely to cause exfoliative dermatitis. One thing you need to note, everybody is going to get exfoliative dermatitis if they take the above drugs. It's only predisposed individuals, yeah? So, you've got allopurinol, aminoglycosides, aminophylline, and you can go through the list. There's calcium channel blockers, carbamazepine, which is an anti-epileptic, cimetidine, gold, lithium, quinidine, etc. So skin lesions, how will the lesions appear? So in dermatology, we notice the most important thing is the appearance of the skin lesions. So the skin will appear to be red, thickened, and scaly. Dermatitis is uniform, involving the entire body surface except for pityriasis suprapilaris, where EES spares sharply defined areas of normal skin. Thickening leads to exaggerated skin folds. Scaling may be fine and briny and may be barely perceptible or light up to zero point 0.5 centimeters. So maybe the scaling will be so little, not little, so tiny that you may not be able to notice it. What we mean by barely perceptible, or it may be large up to zero point 0.5 centimeters and lamellar. Bumps and soles usually involved with massive hyperkeratosis and deep fissures in pityriasis suprapilaris, Sézary syndrome, and psoriasis. Here, telogen effluvium, even alopecia, except for EES arising in eczema or psoriasis. Nails, thickening of nail plates, onycholysis, shedding of nails. Pigmentation in chronic EES, there may be hyperpigmentation or patchy loss of pigment in patients whose normal skin is brown or black. So if you have a skin which is brown or black, they may be hyperpigmentation or they may be patchy loss of pigment, which is basically patchy areas with hyperpigmentation. So on general examination, lymph nodes generalized, rubbery, and usually small. However, they will be enlarged in Sézary syndrome. There will be edema of the lower legs and ankles. When you do a lab examination, you need to do chemistry, where you're going to find low serum albumin and increase in gamma globulins, electrolyte imbalance, acute phase proteins increased. Under hematology, if you do a full blood count, you'll notice leukocytosis. Then you can do a bacterial culture of the skin. Maybe you can do skin scraping and do a culture to rule out secondary Staphylococcus aureus infection. And for blood, you can rule out sepsis. Dermatopathology. It depends on type of underlying disease, parakeratosis, inter and intracellular edema, acanthosis with elongation of the root ridges, and exocytosis of cells. There is edema of the dermis and a chronic inflammatory infiltrate. Imaging, you may do CT scans or MRI. They can be used to find evidence of lymphoma. Lymph node biopsy when there is suspicion of lymphoma. So, diagnosis. One thing you need to know is diagnosis is not easy, and the history of pre-existing dermatitis may be the only clue. Also, pathognomonic signs and symptoms of the pre-existing dermatitis may help, such as disky red color in psoriasis and yellowish red in pityriasis suprapilaris. Typical nail changes of psoriasis, lichenification, erosions and excoriations in atopic dermatitis and eczema. Diffuse, relatively non-scaling, palmar hyperkeratosis with fissures in cutaneous T-cell lymphoma and pityriasis suprapilaris. Sharply demarcated patches of non-involved skin within the erythroderma. In pityriasis suprapilaris, massive hyperkeratotic scale of scalp, usually without hair loss in psoriasis and with hair loss in cutaneous T-cell lymphoma, and pityriasis suprapilaris in the latter and in CTCL ectropion may occur. So, what's the cause and prognosis? Guided depends on underlying etiology. Despite the best attention to all details, patients may succumb to infection or, if they have cardiac problems, to cardiac failure, which is high output failure, or as was often the case in the past, to the effects of prolonged glucocorticoid therapy. So, what is the management of exfoliative erythroderma syndrome? This is an important medical problem that should be dealt with in a modern inpatient dermatology facility with experienced personnel. The patient should be hospitalized in a single room at least for the beginning workup and during the development of a therapeutic program. The hospital room conditions, heat and cold should be adjusted to the patient's needs. Most often, these patients need a warm room with many blankets. Topicals, you can do water baths with added bath oils followed by application of bland emollients. Under systemic, you need to administer oral glucocorticoids for remission induction but not for maintenance. Please take note. Systemic and topical therapy as required by underlying condition. Supportive cardiac fluid, electrolyte, protein replacement therapy as required. So this is a diagram showing exfoliative dermatitis and psoriasis. So I don't know if you're able to see my cursor. If you're able to just follow, you're able to see that there is universal erythema, right? Then are you able to see this thickening of skin if you just follow the cursor? Then here, and then there are large silvery white scales. I don't know if you're able to appreciate it. However, the scalp and nail changes are not seen here, and the patient presented with fatigue, weakness, malaise, and was shivering. And this is another diagram, figure 8. This is exfoliative dermatitis that is drug induced. So this is generalized erythroderma with thickening of the skin, which you're clearly able to see, resulting in increasing scale falls, universal redness, a fine browny scaling. And this patient had developed erythroderma following the injection of gold cells for rheumatoid arthritis. Remember, gold was under the list of drugs that can lead to erythroderma. Then figure 8 showing exfoliative dermatitis in cutaneous T-cell lymphoma. There's universal erythema, thickening and scaling. And you can note that in contrast to erythroderma shown in figure 8.1 and 8.2, the degree of erythema and thickness is not uniform. And the redness has a brownish hue, like if you can see in the previous image and the first image on this screen. They were very erythematous, however, this one has got a brownish hue to it. In addition, this elderly patient had hair loss, massive involvement of palms and soles with diffuse hyperkeratosis, cracks, and fissures. Generalized lymphadenopathy was also present. So that's all about exfoliative erythroderma syndrome. If you did like the video, please like, subscribe, and comment. Thank you.